Thank you. Good morning. My name is Tracy Dowling and I'm the Chief Operating Officer for Cambridge and Peterborough CCG. I also chair 2 of the system resilience groups that come under our proposal, and I'm the designate chair for the East of England Strategic Urgent and Emergency Care Network. Our proposal covers 3 system resilience groups, and they together cover the population of Cambridge and Peterborough, and also take patients in from South Lincolnshire to Peterborough Hospital. It's a population of about 950,000 people. We've got 3 A&E departments, we have 5 minor injury units, 10 out-of-hours bases, and a really diverse range of needs across our population. Our proposal covers all areas of service, and it is the emergency care stream of our system transformation programme, and it will be a work stream within that governance structure. We've got a challenge to close a gap over the next 5 years of £250 million, and we know that we can only do that by having significant change and transformation. Our proposal does cover all areas of service. It covers all ages, it covers children, it covers mental health, and it really is addressing where we've got gaps, where we've got inefficiencies, and actually where there is confusion between which services to use. We will be looking at clinically and financially addressing what happens within our emergency departments, and we will be doing a really intense piece of work over the next year to understand how we get the right balance between community urgent care that's coordinated and specialist emergency care that is specialist in terms of trauma centres, but also workforce challenges for urgent ophthalmology, ENT, oral surgery. I won't go through here everything that's within our proposal, but I do want to pass on to some of our lead clinicians to tell us a little bit more about some of the specific vital areas that we think are really important for our proposal.
Andrew Anderson, GP. I want you to look at this from a patient's point of view, because they're the people we're serving. And how do you access urgent care as a patient? Well, you can go to your GP, you can ring 111, you can ring 999, or you can just turn up somewhere like ED or minor injuries unit. So we've all got all of those. So that's my lead responsibility. Within 111, we were one of the first services to put GPs in our 111 call centre. We checked ED dispositions, reduced them by between 70 and 75%. We're currently expanding that to include green ambulance dispositions, and my vision is to expand that into a multidisciplinary clinical hub, which includes GPs, pharmacists, using electronic prescribing, mental health, nurses, paediatric and dental. So we're going to have direct booking into the 8 to 8 GP services that are currently rolling out in our area, and book into some of the walk-in services in ED. We're not there yet, we need to sort some stuff out. And my vision in 2 years' time is actually to create a multidisciplinary virtual clinical hub covering the whole of East of England. And we've also worked closely with all our other CCGs to actually talk about this concept, and they're all on board. So this will start in Cambridge and Peterborough, but will actually go out across the whole of Eastern England. We've already worked with them. The lessons learnt in 111 I think are transferable to 999. And we've recently wrote the CQUEEN, which means we've got GPs in the 999 Emergency Operations Centre in Norwich, provided by colleagues in Norwich, and they are clinically assessing two key decision points, that ambulance pathway, which is the decision to send an ambulance out, so they're checking some green ED dispositions, and they're also providing support to paramedics on site in terms of where they need to convey or not. We're also developing MyDOS, which is a mobile DOS, which is a Google search engine for clinicians, which tells you where you might be able to send people. And again, that clinical hub there will be part of the 111 clinical hub. So we'll have a multidisciplinary clinical hub across the region supporting 111 and 999 callers, which is the preferred point of access. We've got Prime Minister's Challenge Fund in Peterborough, and that's very unnerving putting 3 minutes up there, you know, puts you off your thread. So we've got GP 7 day a week, 12-hour service. In practices during the week. Weekend we're up at ED, so we're streaming a lot of the stuff. 67% of ED activity just walks through the door. So hopefully we're going to take a lot of that activity out. And we've worked with Ambulance to deliver a protocol with East Midlands Ambulance, and a lot of Rutland patients come to Peterborough, so we're seeing all of this, so that's why you should give us the bid. Over to Alex.
Okay, thank you. I'm a transplant physician from Cambridge University Hospitals, and also a director of Uniting Care Partnership, which is a partnership between the University Hospital and our local mental health trust. We are commissioned by the CCG to deliver integrated care across the whole of the CCG territory. That we developed a model of care, we co-created it with patients, with acute physicians from all the trusts, from GPs, with mental health staff and the voluntary organisations. There are a number of components. At the front front door, we have introduced a single point of coordination. We have a joint emergency team, JET, which is 24/7, made up of paramedics and nurses. We have neighbourhood teams, 16 neighbourhood teams, made up of mental health staff, community staff, community matrons, and co-located with social care staff, located around GP practices. And we've also developed ambulatory care sensitive condition clinics in all the 4 acute providers. One of the innovative parts of our project is that we are funded on a capitated budget. That is over 5 years. It's a very substantial budget, but 5 increasing to 15% of that capitated budget is dependent on meeting a very rigorous outcomes framework metric. So this is not an activity-based contract, this is based on meeting outcomes. So to give you an example, we're required to reduce non-elective admissions, occupied bed days, by a significant sum. The overall aim of this Vanguard project is to improve the experience of patients, to come back to Andrew's point, and the patient experience is one of the important metrics which we measure to ensure delivery of an integrated stream.
Okay, so thank you. So I think my job actually is to corral the enthusiasm of the clinical leaders in our system, like Alex, like Andrew, and to really support them to make these things happen in practice. So we are a challenge system, we're challenged with our performance, we're challenged with our finances, but actually the best thing that we have got is the enthusiasm of our clinical leaders to make change happen. And I think over the last year we've achieved some really significant changes with how we commission and therefore provide urgent and emergency care services. And over the next 2 years, we really are going to make a difference. And we're going to make that difference for all ages and roll out these models of provision, regardless of whether we're successful with the Vanguard or not. We hope we are, because we do think that the support and the development opportunities and what we'll get from being part of a Vanguard will really help us to achieve this big but ambitious project. And it's the job that we have to do anyway. Thank you.
Thanks very much. The next question, I think you've heard it several times, we're just going to ask you what your unique selling point is.
So I think our unique selling point is the progress that we've already made in developing an outcomes-based framework for commissioning that is changing the way in which providers have to work together and the way in which providers remodel services to deliver better outcomes for patients.
Questions now from the floor?
Hi, Jackie Cornish again, NCD for Children, NHS England. Very excellent that you have GPs in your one-on-one centres. How assured are you that these GPs and other staff have sufficient competence in dealing with children's problems to actually direct them to the right place rather than the pillar-to-post situation that usually happens, number one. And number two, excellent that you are looking to give patients a better experience. Do you have processes in place to test the experience of children and young people and their families within your services?
Yeah, I mean, our one-on-one provider, I forgot to mention we're commissioning an integrated one-on-one and out-of-hours provider. The idea sort of came from us. And you know, I think GPs are actually very well placed in doing paediatrics. A lot of our day job is about seeing children. I can't remember the last time I sent a baby in from doing out-of-hours shifts, and I've done lots of those, but my experience is most of children who are taken to ED are almost invariably admitted and sent home the next morning. So I think, you know, GPs are very well placed to actually assess children. We do have a paediatric assessment unit as well up at the hospital for those who are more seriously ill. I see that the GPs in ED will intercept some of those and be well placed to deal with them. And I think because a lot of parents need support sometimes when their babies are ill. We all worry. I've worried when my children were ill a long time ago now. But, you know, we can see them tomorrow or we can see them later. We can book them in for a review. I think we've all, in medicine, we've moved towards this, something's got to be done now, and what is it? And we've lost that ability to temporise a lot, I think. You know, whereas in the old days we say, well, I'll see you this afternoon or I'll see you tomorrow. And sometimes it's just that sort of support that people need. But I think GPs are actually well placed to deliver safe care to infants and babies.
And just to respond about, I think it's a crucial point about how we should develop patient experience, if I can call it that, both for children and their parents. This is an area where very little research has been done. You're probably aware that the Policy Innovation Research Unit produced a big report last year about how you should monitor integrated care through these sorts of surveys. Did not mention children at all. So this is a crucial area which we need to develop. We would hope that in being a Vanguard project, this is the sort of thing that we can develop, because there is an enormous need for proper surveys of experience, both at the extremes of life and in all directions.
Lots of great talk about what we're going to do for patients, but what are we going to do to promote self-care amongst patients so they don't need your help?
So if I can talk about our experience with 111, where we've had GPs looking at the ED dispositions, what we've found is 75% are not sent to ED, 25% are actually sent to self-care. So I think this is where the multidisciplinary clinical hub concept comes in place, where you use pathways to do the initial sieve, and then you identify the complex cases, the EDs, the green ambulances. We can work on what ones we want to see for that multidisciplinary clinical hub to decide. And I think you will get lots more self-care coming out of that. And we've certainly found that with the limited involvement with GPs at the present time.
Yeah, Uniting Care has got a very big stream of trying to promote long-term condition self-management, because it's easy to see how some of what we've been proposing this morning may help us for the first 1 or 2 years, but for the next 3, 4 or 5 years, we are going to have to make an enormous inroad into developing self-care for long-term conditions in the community. So that is a major project.
We've also got a project that's commencing this year around our GPs across the 107 practices doing the training from the Royal College of GPs, virtual training about self-care, particularly to enable patients to care for themselves. And so we're doing a lot about over-the-counter medicines. We've got 2 minor ailment services within pharmacies in the community, and we're wanting to develop that very much more over this next couple of years.
So we've got a couple more questions. Thank you. You started with a £250 million problem. You've got a 5-year capitation incentivised plan. Tell me about the financial rigour that's around that, so that if others want to copy you fast, you don't lead them down a dead end.
Well, yes, rigour is an important word here, and a crucial part of this is making sure that all players in the system, whether you call it an alliance or what, are signed up to the model of care. So we've taken quite a bit of time to involve all the acute trusts. So although Uniting Care is contracted in this model, so are all subcontractors and other parties involved. They have also signed up to that. That is a matter of trying to explain to them the benefits, if I can just give the example of acute trusts, the benefits to acute trusts of admission avoidance policies, where they may be only on 30% tariff. There are a lot of advantages to big trusts. I speak from a university hospital of trying to make sure that only appropriate admissions come. It's getting people to sign up together to the overall plans.
Just want to squeeze one more question in from the back, Reece.
Thank you. Jonathan Benger, National Clinical Director for Urgent Care. Could you just say a little bit more about your outcomes measurement, novel outcomes measurements, what it is exactly you're measuring, how you're measuring it, and how you're tying that to payment?
Yes, so Uniting Care started in April, so in this first year none of the contract is dependent on meeting the outcomes framework. Next year it's 5%, increasing by the end of 5 years to 15% of the total contract value is dependent on meeting these outcomes framework. I couldn't describe them all in one go. There are 64 of them in total. Some of them are patient experience, as I've explained. Some of them are very hard metrics, reducing non-elective admissions, reducing occupied bed days, reducing the proportion of people who have gone into reablement who 91 days later are not in their usual place of residence. So there's a whole range which is divided up into into 5 different domains of experience, outcomes, safety.
Thanks very much. I have to stop you there. Thank you very much, Cambridge and Peterborough.